Good afternoon, everyone. I'm Diane Perez, and on behalf of the Florida Alcohol and Drug Abuse Association and JBS International Incorporated, welcome to today's webinar entitled Opioid 101, What Every Foster Parent and Kinship Family Needs to Know About Opioid Use. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, JBS International Incorporated, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options have been posted in the chat panel too. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 10 business days. To access the recording, go to www.fada.org. Also, a PDF version of this PowerPoint presentation will be emailed to participants. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADA as part of your registering remains confidential. Statements of credit will be posted within 10 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note that the evaluation will close at midnight on Thursday, May 2nd. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you're a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you don't need to provide your certification number when you register with our site. Note, please, that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. And now I would like to introduce our presenters. Pamela Petersen-Baston has 39 years of experience working in a variety of capacities in the health and human services field, including serving appointments under 2 Florida governors to manage Florida's publicly funded drug prevention and treatment system. After leaving state government in 1995, she moved to Key West, Florida, and ran Safe Port, the largest family-centered treatment program in the country at that time for child welfare involved pregnant and parenting women with concurrent opioid, methamphetamine, and other substance use and mental health disorders, and their children, serving 100 people, including children, at any given time. For the past 24 years, Pam has worked in various capacities with JBS International in every state in the country and is currently providing technical assistance to states and tribes to address the opioid crisis. Danielle Austin is a full-time working mom and foster mom. She and her husband have fostered for over 3 years and have had 18 placements lasting from as little as 6 hours to as long as 23 months. They have 3 biological children of their own, ages 18, 8, and 7. Danielle and her husband made the decision to start fostering after their 8-year-old was born deaf and received services from their local Early Steps provider, the same provider that held the foster home management contract. Though the advocacy work and contacts she made while getting services for her son, she learned about the need for foster parents. Danielle passionately advocates for all the children in her care and enjoys making a difference in both the children's and their families' lives. When they're not working, the family enjoys spending time with the extended family, going to the beach and watching their sons play baseball. Sherri Dirmann and her husband fostered 11 children between 2009 and 2016. They adopted 2 of those children, their 8-year-old son and 5-year-old daughter. Their biological son passed away in November. He was a great big brother to all the children who came through their home. Sherri and her husband decided to foster after losing 2 babies and being unable to have more biological children. They felt that they were able to care for children and support their parents while they worked to reunify with their children. Sherri and her family enjoyed trips to Disney and the beach, going to movies, and playing outside. And now I would like to turn the presentation over to Pam. I will turn the presentation over to you.
Okay, thank you very much. Welcome everyone to Opioid 101, what every foster parent in Kinship family needs to know about opioid use. So this training today is sponsored by the Florida Alcohol and Drug Abuse Association. Excuse me, having a little technical difficulty. Here we go. Sponsored by the Department of Florida and Children and Families and the Florida Alcohol and Drug Abuse Association. And the funding that supports this training is from the Substance Abuse and Mental Health Services Administration, SAMHSA. That's the federal government who gave funding to every state in the country to address the opioid crisis. And Florida had the leadership and foresight to realize that you can't put millions and millions of dollars into the opioid treatment system to expand treatment without also bringing along the workforce, particularly the workforce directly affected by the opioid crisis, including those partners and referral agencies and such. So Florida is one of the leaders in the country now providing this key training. The learning objectives for today's webinar: identify a common pathway that can lead a parent to use opioids in ways that potentially contribute to child maltreatment. Discuss the many effects of caregiver opioid use on children. Listen to stories and engage in discussion with Florida foster and adoptive parents to learn firsthand about the unique challenges of caring for the children of the opioid epidemic. And of course, I know that Diane mentioned we'll be hearing from Sherri and Danielle, and they have some incredible information and experiences to share. And lastly, describe effective treatment and recovery responses to address parental opioid use. So we will kick off today's discussion with a a discussion around the common pathways to opioid use, and there are many, but we will focus on one in particular, that being pain management. I want to say right off the bat that it's totally understandable that anyone who works with families that, especially parents that struggle with opioid use, it's understandable to be angry when we see what the effects are from the parental opioid use on the children. What we're hoping today's webinar will help to do is to help us all look more broadly at and appreciate how complicated the pathways to opioid addiction are and all the other factors that go into that. And that's not to not recognize the harms that parents can cause or to in any way diminish their accountability, but to understand that this is a very complicated disease and the pathways to this particular disorder do not in every instance even involve conscious choice. And we'll talk about that as we go through today's webinar. This quote came from one of the foster parents on our webinar today. Developing a relationship with the foster child's bio parent humanizes them. It helps my level of compassion to know where they came from, where they have been, and why they made the decisions they made. And that is a good way to kind of set the tone for our discussions today. So it may surprise you to know, as it relates to prescription opioid misuse, the pain medication misuse, that back in the mid-1990s, the Food and Drug Administration approved one of the first pain medications that you may have heard a lot about called OxyContin. And there were other opioid pain medications that came out about that time as well. And these were only for short-term pain. However, physicians were having such great success reducing pain, and the patients liked the pain relief, and so it became something that lasted for longer-term chronic pain management, even though that's not what these medications were initially developed for. So what happens is that patients, really anybody who takes pain medications, builds up a tolerance, meaning that after, in this case, about 4 to 8 weeks, the amount of medication that they were taking, according to their doctor's prescription, was no longer helping the pain as much as it had in the past. So they would take a little more, and the doctors were going back to the Food and Drug Administration saying, "Are you sure this is okay? You know, is it a problem that we're keeping these patients on these medications for so long?" And the doctors were assured that these pills were safe, and the reality is they were wrong. And many of you now are probably aware of some of the difficulties that these medications can cause. So many individuals just literally did nothing more than what their doctor or other prescribers told them to do and got in trouble with opioids, got so badly addicted that it ended up, causing lots of problems in their lives that we'll talk about throughout the webinar today. Other things that happened at that time that were affecting the opioid use crisis is you might be familiar with something called used to be the 4 vital signs, and that's your pulse rate, your temperature, your respiration rate, your blood pressure. Well, over time, pain management became sort of the 5th vital sign that was promoted by the American Pain Society and adopted by the Veterans Administration and the Joint Commission on Accreditation and Healthcare Organizations. And pain control became very much linked to patient satisfaction, so that when folks were in a hospital receiving pain medications, they would be given surveys to see, how their care was at the hospital. And if they did not have good pain management, they would give bad survey results. And those survey results literally were connected to reimbursement by the hospital. So there were all of these forces that were happening that were creating conditions in which these medications were being very freely provided. And again, nobody did this intentionally, thinking that this was a problem, but they were all reassured that this was all okay. Now, Florida is in the process, or they've been reducing now for years and years and years, any kind of over prescription of opioids. One of the tools that they use for this is the Prescription Drug Monitoring Program, PDMP, and that is a situation where the pharmacies have to, and any other prescriber has to make sure that the information when they give out an opioid or other medication that's a controlled substance, it has to be identified in a database so that a patient won't end up getting multiple prescriptions at one time by accident. So that helps a great deal. Even with these kinds of processes in place, you might be aware that have a situation where, I think it was in Kentucky and Ohio 2 weeks ago, there were 60 physicians, and also that included some dentists, that were arrested in one of the largest opioid busts in the country. So just know that despite what is happening, to try to bring this over prescribing down, that this is still happening in some locations. So here is just a quick glance at the various strengths of opioid medications, ones that you might be aware of. Codeine being one of the weaker opioid prescription medications, and then you have, morphine and oxymorphone and oxycodone and hydrocodone, and then the most strong one being fentanyl. Fentanyl you probably have heard a lot about in recent years. One is that you can still get fentanyl if you're in a hospital. You might have access to that. It's a very significant pain medication. It's not uncommon for cancer patients to have fentanyl or fentanyl patches. It's available in hospice. It's not typically provided for routine pain management, so this is kind of more of an extreme situation. But as you may be aware, fentanyl is coming over from China and Mexico and ending up on the streets and being put into various types of opioid medications. So they can use pill presses to create what looks like regular pain medications that you would get through a pharmacy that are really made, overseas or in someone's garage in a pill press, and then oftentimes this fentanyl is sprinkled in, which creates a very intense high that's very popular among the users, but it's also a very deadly high. And I'm sure most of you have heard about all the various overdoses that are so frequently linked to fentanyl. So we have the amount of opioid prescriptions that have been dispensed, according to the CDC, has quadrupled since 1999, but the pain that Americans report has remained unchanged. So what this is basically saying is, that there's really no reason to support the extensive amount of opioid prescriptions that have been happening over the years because the pain levels have remained the same. This we're not going to spend a lot of time on, but I just want to show you to the right of this pie chart that you can see that the majority of the pain relievers that are misused around the country are actually coming from, either knowingly or unknowingly, from family, friends, relatives. So in other words, one of our parents might be getting them from one of their own relatives, or might take them from someone's medicine cabinet, that the majority is not coming from a legitimate medical prescription, but rather a situation where they're getting it from from others. While we talk a lot about the prescription access to the opioids, in prescription in particular, it's not atypical for a child welfare system involved parent with an OUD to have begun their use by intentional or unintentional access from their own parents. So in some families where you might have had, a lot of blue-collar workers who worked in construction or in the mines or in other hard labor jobs where they may have experienced a lot of pain, or families that have had, degenerative health problems and such that might have been on pain medications, and children grew up seeing that reliance. And of course, especially if this happened a while back, there was no real stigma around the pain medications. We didn't know how dangerous they were. So they may have grown up seeing this as something that you do. And also, as we'll discuss in a minute, there are the many instances where a parent that we have in our system today was inducted into opioid use against their will as part of a domestic violence situation, which we'll chat about in a minute. So this is a kind of a typical scenario. This is a case from Monica, a case study, that the timing and severity of the opioid crisis, it varies among communities around the country. However, the tragic pattern is all too similar. Prescription opioids come first, but when those prescriptions end, and sometimes it's fairly abruptly that these prescriptions end from their prescriber, and then that leaves the users desperate enough to try street heroin. And that's what happened to this particular person, Monica. She was prescribed Percocet painkillers after a high school car wreck and then started buying stolen pills, so that she didn't have to go through painful withdrawal and so that she could address the pain she had. And then finally she ended up on heroin. And this happens, if you look at the current heroin users now, about 75 to 80% of them literally started in this same way. They started on a prescription, often from a car accident, a high school accident, and they ended up addicted. And then when they couldn't get the prescription anymore, then they turned to the street for heroin. So there's a lot of connected adversities when we talk about opioid use disorders. Women who have been diagnosed with opioid use disorder are more likely to have experienced domestic violence, sexual violence, and childhood sexual abuse. They're more likely to have been prescribed opioids for chronic pain. They're more likely to self-medicate to cope with trauma. And whether opioid use disorder increases risk for victimization or whether the victimization leads to OUD, the consequences, that are adverse are the same. So there's lots of pathways that apply here, but they generally are not positive experiences. So this is one very negative experience, which is opioid use and sexual exploitation. Perpetrators of domestic violence have caught on to how strong opioid medications can be in terms of controlling, we call it chemical control of another person. So if you can imagine a scenario where you have, let's say, a woman who maybe she has a couple of kids and she's a single mom, and her husband or her, or I guess her boyfriend comes into the picture, and let's say he's abusive to her, and she's taking, let's say, pain medications, he can hold those pain medications from her, withhold them, and then require her to do whatever he wants her to do before he will give them to her. It's a form of domestic violence or a form of chemical control. This happens, unfortunately, with children and many times happened with the adult parents that we work with today. When they were kids, their uncle or their mom's boyfriend or their own father or someone may have inducted them onto this, opioid, very addicting medication, and used that to keep them under their control so that they would be more easy targets for sexual abuse and such. I met more people than I can count who got inducted in opioids either without their knowledge or against their will, and oftentimes as children. And I've met with kids as young as 8 and 10 who were literally inducted without their knowledge. And eventually they knew something, was wrong, and that they had this craving that had to be maintained, or they were sick, but they were not aware at the time that it was happening to them, that they were being forcibly brought into an opioid addiction. So I say this because we don't want to make assumptions. It's not that every parent is out making bad choices. These pathways are very complex, and we just need to understand each individual parent, what was their individual pathway and what are the repercussions for that. So if they ended up being forced against their will, and sometimes it's not as obvious as being forced as a child, it may be, a couple and the woman, again, being a single parent, maybe a lot of pressure, not a lot of finances, and she meets a guy that she likes a lot, and he's starting to help and take care of her. And first they start using one kind of drug, and then he tells her, what are you, too good for me? You'll smoke pot with me, but you're not going to, shoot up, or you're not going to use these pills. And so, she makes a choice that, do I keep the roof over my head and keep life going along good for my kids by just caving in this one time, not realizing how addicting these opioids can be. This quote from Angela Brown is very powerful. If you take away substances and don't deal with the trauma and pain underneath, then you leave the survivors completely bare and exposed with no anesthesia. This is something that we see all the time. The trauma and pain that these families have gone through, and particularly the opioid-using women, if this is not addressed in treatment, then it will constantly undermine their care. And in some places, this is being done very well, really good, high-quality treatment that includes an emphasis on trauma, and in other places, not so much. So if you are working with these parents, whatever you can do to connect them to good trauma support, particularly for women, about 80 to 90% of whom have had sexual abuse and trauma, that will really make a big difference in their life and also in their treatment outcome. So we're going to shift now into some effects of caregiver opioid use on children, and we'll talk about toxic stress and also older children and adolescents and what the effect on them is. So we know that excessive or high levels of prolonged exposure to stress is very dangerous for anyone, but particularly young children. Increases in stress hormones are protective and even essential for survival. So in other words, we know that just living in the world today, we are all going to experience stressful situations at some point, whether it's a death of a loved one, whether it's an unexpected injury that, causes problems in our life, whether we lose a job, get divorced. We know that there is no smooth ride. We all experience stress. And we learn that from a very young child. So having some stress is good because it helps us learn, well, we can get through that and we can survive, and this is how we do it, and then we prepare for more difficult problems ahead. However, when that stress is excessively high or happens over a prolonged period of time, it can be harmful or even toxic, and can lead to chronic wear and tear on multiple organ systems, including the brain. And here is a photo. It's quite interesting if you haven't seen this before. If you look from on the left as what the neural connections look like for a newborn and how rapidly our neural connections grow as we get older until you see then the adult slide there. And these neural connections happen each second, a million of these each second. I mean, that's hard to even wrap your head around, but that's how rapidly these are developing. And that's faster in the growing child's brain than at any other time in life. During the first year, a child's brain doubles in size, and by age 3, they will have reached 80% of their brain volume. Excess neural connections makes a child's brain especially sensitive to external input, such as relationships in their environment. And so think about a case of an opioid-using parent who perhaps has a baby in a crib, and a mom or dad, shoots up, or they take some medication and they kind of nod out. They're really not all that coherent, and the baby is in the crib crying and crying with a soiled diaper. And, should child welfare get involved and see there's a terrible diaper rash from this child being, left in a soiled diaper, that represents so much more than just the rash. What that represents is that baby, when uncomfortable with a soiled diaper, cried and cried and cried, and no one came. There was a lack of responsivity, a lack of responsive care. And so all of that stress that baby experienced trying to get some help to no avail is what contributes to this very serious toxic stress problem. I want to talk a minute about serve and return. I think Diane mentioned that I used to run this huge program in Key West called SafePort, where we put all entire families into treatment. Didn't matter how many kids they had, how old their kids were. They all moved into their own apartments, and we had a huge family treatment campus. Totally amazing program. Well, one of the things I learned, I moved in there to actually live with these families because they were all very poor and in public housing, and I didn't have a lot of credibility with that population, and so I wanted to move in and learn firsthand what to expect. And one of the things that shocked me that nothing prepared me for was the assumptions that parents make when they don't have better guidance from their own parents. So, for example, many parents would not talk to their babies. And when I would talk with them about this, they would say, oh, well, they don't develop language skills till they're, 2 or older. And so it's kind of pointless to talk to them. Not realizing that that is how the babies exactly develop language skills is from that, back and forth, that serve and return, where, the baby babbles and the parent looks at the baby and babbles back and makes, kind of silly noises and faces, and they have this intense connection and it encourages the baby to keep going. And so, again, not only do many of the parents that we work with not have this background to know to do this, but they, if they're using substances, then their ability to even get engaged and do all of this serve and return and this responsive care is greatly diminished. The good news is that we are making a lot of progress on understanding how valuable these early experiences and environmental influences are, and we know that they can have lasting signatures on the genetic predispositions that affect the emerging brain architecture of these young children, and we're making increasing investments in preschool years to promote the foundations of learning. So in some instances, we are able to make these improvements to sort of counteract some of these negative things that might be happening in the home. Now, this is an area of growing interest also is children and adolescents and teens. We know that it's important to work with the 0 to 5 and because of all this developing brain architecture, but at the same token, the children who are older, especially if their parents have been using substances for a long period of time, they, to some extent, might have even more damage because they've had more years of toxic dysfunction in the home. We know that 30 to 33% of children who grow up in a home with a parent with an opioid use disorder meet diagnostic criteria for disruptive disorder. 21 to 30% meet diagnostic criteria for anxiety or mood disorder, and 47 to 59% exhibit substance misuse behaviors. And so we know that this is a family illness and something that we will see a lot of. And so we really have to do a lot to make sure these children get the help that they need. One area of emerging interest is health effects of early.
Just one moment. Like technical difficulties, we'll be right back on.
Wait, can you hear me? Can you hear me, Diane?
Yes.
Okay.
Yes.
I will keep going if you will turn my slides. For whatever reason, our office just lost internet connection.
Okay.
So if you will, I luckily have it open on my screen. So if you will, I'll just let you know when to move the slides, and we should be good to go. Okay.
Okay.
All right. So all right. So we can just stay on the slide that you were on a second ago, and basically, what we are we're looking now at adolescence and the effects of early and prolonged stress. And what's so interesting is that we know now that stressful childhood events are linked to inflammation in adolescence. And I just think this is very interesting research. But the other thing is that this inflammation can be identified by medical teams and they have biomarkers that can help health providers identify kids at long-term risk for health problems. So we're making some advances in this area. Next. So the effects of parental opioid use on children. Children are likely to experience significant neglect, trauma, toxic stress, or at a minimum, a lack of a responsive parent. Parental capacities are likely to be impaired, and parental sobriety will not necessarily by itself address child, adolescent development, mental health, or substance use disorders. So one of the things, and I think any foster parent on this call, on this webinar, knows this to be the case, that it isn't enough to just get treatment for the parent. That, you know, that's a good place to start, and we certainly want to make sure that we get the parent help, but that the likelihood that that alone will be sufficient to address the child's problems is not the case. So we really need to treat the whole family. Next. So the other thing that's good news here is that the concept of resilience. And so we know that fostering resilience is something that often happens when we get other individuals involved, whether that is a non-substance using parent or another family member, whether it's a foster parent, that by having these other family members involved or friends or other support of others, that it can make a big difference in a child's life. And so that's something that we always want to promote. Next. So now we're going to move into the, what do we do about this opioid use disorder? What does effective treatment look like, and what are some of the issues associated with treatment? Next. So some of you probably already know this, that what the effects of opioids are on a person, that after an initial pleasurable rush, the person that's using opioids may be very drowsy for several hours. They may have clouded mental functioning. Repeated use often results in addiction, where seeking and using the drug becomes the primary purpose in life. Now, I have worked in my 39 years with literally thousands of substance users, and, you hear from them all the different kinds of substances that they use and what they like and what they don't like, but opioids have always been sort of in its own category, where it is something that they tend to speak of more favorably, like there's no other substance quite like it, especially helping them with their serious drug problem and with their serious trauma, that it gives them like a break from all of these problems that they're having. Okay, so Diane, I am now on opioid use, what we know. All right, and then the next slide. So the effects on the body and brain of opioid use, if you can just push a few more slides ahead. Effects on the body and brain. When someone uses opioids, they have drowsiness, mental confusion, nausea, constipation, respiratory depression. Opioid meds act on the brain's reward centers and can induce euphoria, particularly, keep on going, couple more, and then I should be able to take it back. I just got my connection back. Go one more, and then I can take it from here. So the opioid meds act on the brain's reward centers, and the thing about this is that depending on how much opioids they take, that would give them potentially a different effect. So, we don't know how many of these individuals are getting fentanyl by accident. They go out on the street, they get, substances from the street. They don't know whether someone put a little fentanyl in them. They don't know how much of a substance opioid they received. So the effects that they have may be will vary by what they actually got in their particular heroin or other opioids. And by the way, they've perfected these so much now that you can have these pills look almost exactly like the ones that you would buy over the counter. So it's incredible what they look like and how easy they are to fool the user. So Diane, please advance. It's not going. Oh, there it is. Sorry. Opioid withdrawal. So many of you will appreciate this, that if you remember having the flu, and let's say the worst flu you ever had, and that you just laid on that bathroom floor and just, would do anything to, or maybe if you ever got intoxicated and got so drunk that you, like maybe when you were a teenager or something, or college, and you just said, I will never drink again, I am so sick, you just are laying on that floor and you just, want to die. If you take that experience, that memory, and you multiply it many, many times, and that is what opioid withdrawal feels like. You would have excessive perspiration, shaking and muscle spasms, severe muscle and bone pain, vomiting, nausea, diarrhea, irritability, insomnia. The worst part is this real creeping anxiety that comes over when you have this withdrawal, that you just cannot shake it. And dilated pupils, rapid heart rate, and death is very unlikely from opioid withdrawal, but it feels like that you're dying. And so this is what we call being dope sick. And basically, individuals who have opioid use disorders, it's not that they are out to get a good buzz and out to get high. They are trying to avoid being dope sick. That's the main objective. And so this quote explains this quite a bit. I had nothing. My life was broken down into 4 to 5 hour increments to get high, to put off feeling sick. So literally the person has to, if they have a serious opioid use disorder, use and use and use every 4 to 5 hours to avoid going into withdrawal. So I am not a doctor. I don't play one on TV, did not stay at a Holiday Inn Express, but I am going to put in the simplest ways that I know how a brief explanation about the effects of opioids on the brain. And this is something, as we train throughout the state, is probably the most surprising information for folks, at least the feedback that we've gotten thus far, that a lot of folks don't realize how opioids affect the brain and how complicated this can be. And so as human beings, all of us, we produce opioids within our own bodies. All of us do. And that's called endogenous opioids. So it's a naturally occurring chemical in our bodies. And we know these we call them endorphins. And if we have any pain or excitement, these and mostly excitement, these opioids kind of come into play. So delivering a baby, or watching the birth of a baby, or having sex, or enjoying a good meal, these are all experiences that will activate these endorphins and give us this, pleasurable feeling. And then if we're having pain, like if we break an ankle or we have some injury like that, the endorphins kind of mute the pain, at least temporarily, until we can then get some, professional care from a physician. So we all have these naturally occurring. And then if somebody were to so look at these photos here, and if you see, for example, the brain on the left and those little Ys, just imagine those are like little docking stations, and the little blue dots are naturally occurring opioids that we all have. And those are little receptors, that they go in, and everything's great. When you look at the photo on the right, or the little graphic on the right, those little purple dots is signifying that we're introducing external opioids from heroin, from pain medication. So we're getting something that our body's not producing, and we're adding it to the mix. We're taking those in our systems, and now our brain has our regular generating opioids, and then the external, and the external are called exogenous, and they come from the outside. Well, what happens is over time, those, if you look at the blue dots, those begin to be produced less by our brain, because we're getting all of these outside, externally produced opioids, so we don't really need the ones internally as much. And so what happens is our body starts to make less of the naturally occurring ones because we're getting these, external ones, that these, ones from taking drugs. So what happens is that is what creates this addiction, both a physical and emotional addiction. And I want to say that in some cases, when a parent has an opioid use disorder and it takes a while for their brain to heal from all of this, when let's say their child is taken into out-of-home placement, let's say in foster care, and the parent gets their first visitation, and you're expecting this parent to be so excited to see their children again, to have, be reunified at least temporarily on their first visit or what have you. And when the parent comes in and they don't seem all that excited to see the kids, and there's a term called anhedonia, but it's like a lack of pleasure. That could very well be that their brain has not yet healed. So if they're no longer taking the external opioids from heroin or from their pills, and the internal opioids, that their brain had been making haven't started back yet, or haven't started back at the volume that it needs to, then they are not going to be they're not going to show that pleasure because they're not going to feel that pleasure, that joy. So we have to be careful that we don't make assumptions, especially if we know somebody is recovering from an opioid use disorder, that it will take each individual a different length of time, again, depending on their drug use history and whether they had a lot of high powerful opioids, whether they had a lot of fentanyl, what other kinds of things might have been in their drug mix. So that's why we need medication for opioid use disorder. The effects on the brain are very complicated, and typically the changes in the brain caused by opioid dependence will not correct themselves right away. Even if you stop using opioids, that doesn't instantly revert back to how it was. It takes time. And the changes in the brain can trigger cravings for the drugs months and even years after a patient has stopped using opioids. Overcoming opioid dependence is not simply a matter of eliminating opioid substances from the body. Like, you don't just send someone to detox and say, hey, look, we just eliminated the opioids, we're good. Now just throw some counseling at them and they should be good to go. This is so complicated, the effects on the brain, that the medication that we have as part of medication-assisted treatment does help with that. It will help reduce the cravings and help reduce all of the, the sickness and the withdrawal that they feel. And then especially when they get counseling on top of that, so they get this combination of medication and counseling. So unless we offer this restorative rebalancing treatment, then these functional brain imbalances can result in worsening of their disorder or sabotage their recovery efforts. And just remember that when you just detox someone, that doesn't, that doesn't help them with all their trauma, with all their relationship, repair that they have to do. That this is all an interactive process of medication and the treatment. So what are some of the benefits of medication? It's well studied, it's effective, it's evidence-based, and it can significantly improve treatment outcomes. Patients that take medication for opioid use disorder are considered to be in recovery. So we get very upset when we hear things like, especially from people in our field who should know better, or when we hear sometimes judges or other folks tell a parent in the child welfare system, well, you need to get off of that treatment medication because you're not in recovery yet, and until you're in recovery, you're not getting your children back. And that is completely incorrect. There's no difference in someone taking treatment for an opioid, medication for an opioid use disorder, and then a patient taking medication for anxiety or depression, for a mental health disorder. It's, grossly unfair to expect them, to practice medicine without a license by telling someone that they have to get off the medication that is life-saving, that is restoring their brain balance, because someone's idea that means that they're not in recovery. So that does increase social functioning and retention in treatment. So we know that if someone does get on medication, they have a much, much higher success rate than if they go to an abstinence-only program. Numerous studies have documented that patients treated with medication are more likely to remain in therapy compared with patients receiving treatment that does not include medication. Research has documented that the combination of medication with counseling and recovery support, which we'll talk about in a minute, is more effective than substance use treatment without medications in treating OUD. Available research indicates that medication-assisted treatment improves treatment adherence, reduces the risk of overdose death, and reduces the risk of contracting associated infectious diseases such as HIV and hepatitis B and C, among other outcomes. So just remember that some of these opioid medications are crushed into a powder and injected. Heroin is often injected. So if we don't get them on a medication that's safe and effective and they're using street medications, then it can increase this disease transmission. Medication-assisted treatment helps to stabilize these clients. So, you can stabilize a client with just medications alone, but the counseling is what also makes the difference. The parents that are involved in the child welfare system typically have such a range of interrelated problems that they really need the medication with the counseling and the recovery support. Now, there was a study done by the Assistant Secretary for Planning and Evaluation, and they went around the country and looked at, I think it was 11 different states, and looked at the treatment systems, and they found that those that referred their families to medication-assisted treatment had much better outcomes than those who didn't, and that they were much more likely to regain custody of their children. And in fact, a program in Kentucky where they did a lot of their research found that the clients with a history of opioid use who received a year of medication-assisted treatment increased the odds of retaining custody of their children by 120%. I mean, that is just absolutely phenomenal compared to those who did not receive MAT, who got usual and standard abstinence treatment. However, the sad part of this is that fewer than 10% of the clients, opioid-using clients in Kentucky's child welfare system in these areas studied, even received a referral to go to a MAT program. So, in some cases, we are literally condemning these clients to, high risk for fatality by not allowing them or facilitating their connection to an option of medication-assisted treatment, because it can make such a difference in healing their brain and in saving their life and helping them become a healthy, functioning parent again so that they can get their children back. So we'll talk a few minutes about some of the medications before we go to a break. This photo here is a photo of methadone. That is one of the 3 types of medication, FDA, Food and Drug Administration approved medications. What you'll see here in that photo is you see the man drinking a little cup. It's like a little Dixie cup that will have, in this case, liquid methadone. It's usually mixed with Tang or orange juice or something. And you see the nurse who will have administered. She will have looked up his chart to see what dose he was on. She gives it to him in a little cup. He'll drink it, and she'll make him speak to her to make sure he doesn't hold it in his cheek and spit it out when he gets outside of the clinic. So that's one of the diversion prevention strategies. But what's great about methadone, it's one of the most highly effective treatments for opioid use disorder. It's highly regulated, certified, and accredited by SAMHSA and by the DEA. And we've had probably close to 50 years of research on this particular medication. We know more about that than the other ones. Now, the difference, though, is that you have to go every single day to a methadone clinic for about the first 90 days before you can start getting take-home medication. So that is a very difficult situation for some clients. I was doing some training for this whole initiative, and met some counselors who were telling us that some of their clients have to drive 2 hours per day to get to a methadone clinic. And you imagine that's 4 hours round trip. That's half a day spent. They all get together in a van and they go to the methadone clinic. And you wonder, how long are they going to be able to keep that up? Especially they don't always have transportation or gas money, and it's hard to work or to spend time with your kids when half your day is spent literally in a van, not even including the time you spend when you get to the clinic waiting your turn or getting your counseling. So we have to really look at the big picture here when we refer people to treatment to make sure that they can access the treatment that they're being referred to. So because we have such a big opioid crisis, about 20 years ago or so, another treatment medication was developed called buprenorphine. You might know it as Suboxone or Subutex. And that is a medication that can be provided like any mental health medication would be, where you go to an outpatient center, or you get a doctor who will write you a prescription after they do a review of your situation and a medical, physical. And this medication also will stop the craving and will stop withdrawal. And it's something you take every day, or they have it in a shot form or even in implants now that can go in your arm. And so basically, this is the different kind of medication that doesn't involve you having to go to a clinic every day. But the nice thing about the methadone program is you're there every single day, so someone's checking on you, they're looking at you, they're offering counseling when you need it, they're there for a crisis because you're showing up to a program every day. So I'm not saying one is better than another, just pointing out that there are differences in these various medications, and that some of these make more sense for some clients than others. Also, there are now waivers that nurse practitioners and physicians can take to enable them to prescribe buprenorphine, and it can be done. It's called a waiver training, so that we can bring more of these people trained to administer buprenorphine. It's not as difficult to be able to be a provider now as it was in the past. Want to mention briefly naltrexone. That's another medication. You might know it as Vivitrol. That can be administered by a physician or a healthcare provider, and that also blocks cravings and keeps somebody who's addicted from being dope sick, going in withdrawal. Don't confuse naltrexone with naloxone, which we know is Narcan, and that's the medication that reverses overdose. So we have naltrexone and we have naloxone, and they're different. I'm going to speed up just a little bit here. Methadone and buprenorphine, I already said this, they reduce the cravings, they suppress the withdrawal, and they block, in the case of naltrexone, blocks any euphoria by preventing opioids from attaching to the opioid receptors in the brain. So these are medications that are really meant to address these problems we've talked about, the risks for getting back out and using again, having all of those cravings. Methadone and buprenorphine do not substitute one addiction for another. When they are treated, these patients, they don't get high. And if you are seeing patients that appear to be high, it could be that they're in the early stages of their medication, and they just might not have gotten their proper dose figured out yet. It takes a while to calibrate their dose, just like with any mental health medication. There are instances where some clients may use other medications on top of their treatment medication. So you really need to communicate, if you're seeing these symptoms, to their treatment provider, because that's not the intended effect. That's not what's supposed to happen. We do have medication-assisted treatment for pregnant women, and it is, again, the standard of care, and it does help. This whole transition of parenthood is a great opportunity for motivation to get pregnant women to want to become involved in medication-assisted treatment, to the new baby and a new opportunity to start over and have a healthy family. We do have, if a patient is either taking heroin or other street opioids, or even if they're taking medications from a methadone program or taking buprenorphine, they can have a baby that has neonatal abstinence syndrome. These are about 30 to 80% of the time this will happen, but this is expected. It's an expected and treatable consequence of opioid exposure. We've made a lot of progress now into how we keep the babies comfortable, both with medication and also non-pharmacological interventions. It is a temporary condition. It just basically happens because the baby was getting the opioids through the umbilical cord, and once the baby's born, then they're no longer getting that, and so some will go into withdrawal. But reducing their dose of medication-assisted treatment does not reduce their expression of neonatal abstinence syndrome, so we want all of this to be handled with the physician. We don't want to get in there and say, well, bring her back down. We don't want her on these medications. We're trying to reduce neonatal abstinence. This is all a very complicated medical situation. Also, some of the things we see with babies with neonatal abstinence is also from smoking cessation, from nicotine withdrawal, because a lot of these, babies also have nicotine exposure. So we want to also do smoking cessation. Breastfeeding is highly recommended, even when moms are on the medication-assisted treatment, and there's only a few instances where we don't recommend that, and that's if they have HIV. Or if they're using other illicit drugs. But the amount of medication that gets through to the baby in the breast milk is just a teeny amount. And the feds through SAMHSA and through all these other groups speak about how important it is for pregnant women to stay on pharmacotherapy, on these medications-assisted treatments during their pregnancy, because withdrawal during pregnancy causes a high failure rate and causes them often to return to use. And if this goes undetected by us, then you now have a baby that can be exposed to toxic stress. Just a couple more minutes here and we'll take our break. This is the SAMHSA guidance, and I read it directly because it's very important. They say pregnant women with opioid use disorder should not be encouraged to withdraw from pharmacotherapy for OUD during the pregnancy or shortly after delivery. It's the recommended standard of care. It's the best option for pregnant women. And remaining on pharmacotherapy will help her avoid a return to substance use, which has the potential for overdose or death. A decision to withdraw should be made with great care on a case-by-case basis with additional support, such as close observation, being put in place. Caring for a young child can be viewed by a parent as a very meaningful opportunity. It's a great, opportunity and hopeful, potential future. So this is when motivation can be very high, and when we want to try to get these moms that have opioid use disorders who are pregnant to take better care of themselves and their family by getting involved in treatment. And lastly, they cannot always get to all of these medical appointments and all of these medication appointments and counseling and trauma appointments if they don't have recovery support services. Just remember, a lot of these parents do not have transportation. They don't have a lot of family or friends. They may have burned bridges from their drug use, from stealing, or from other bad things that might have happened. And so, here they are, they're in child welfare, they have case plan meetings, they have to go for drug testing, they have to go to court, they now have to go to medication appointments. They have all these things they have to do, which for any of us would be very hard to do. And we have a lot of support, but they often don't. And so what we want to make sure is we haven't set them up to fail, that they have enough recovery support services, which is a collection of community services that can provide emotional and practical support for continuing their remission, as well as a daily structure and rewarding alternatives to substance use, so that we engage them in fun, exciting activities and to be part of the pro-social community so that they, can have and build a healthy life. And here's just a few examples of the kinds of recovery services and resources they're likely to need: housing, education, employment assistance, social resources, and overall health and well-being. So they have, these are all things that hopefully are being provided through case management. And lastly, it's more than just checking a box. And as we're going to take a break here in a second, but our foster parents will talk a little bit about checking a box. That often what happens is the parents get so concerned with all the boxes they have to check. Have to get a job, check. Have to get safe place to live, check. They have all these things they have to do to get their children back if the children have been temporarily removed. And often those are in conflict with the type of treatment they need. So they may need a residential treatment program if they've had, years and years of opioid use addiction. And so we have to take a step back and look at all of the things that we're putting on these families to do, and to make sure that we're communicating across the systems, that we're not setting someone up to fail by putting them in an outpatient program if they needed residential, just because the only way they could get their boxes checked is if they're an outpatient where they can go get a job. So we'll talk a little bit about this as we get to our families when we come back from the break. So thank you for your patience with our little technology blip here. Glad that it worked out okay in the end. And Diane, I'm going to turn it over to you to announce the break rules.
Let's go ahead and take a 5-minute break at this time. We will reconvene at 3:10. So everyone, take a little break, and then we'll get back started with to hear from Miss Danielle. We'll talk to you soon. Hello, everyone, and welcome back to today's webinar. Danielle, if you're ready, I'll turn the presentation back over to you.
Hi, everyone. My name is Danielle Austin. I am a local foster parent. I'm a foster parent in Tallahassee, Florida, in the North Florida Panhandle. My husband and I became foster parents in 2015, November of 2015. As they stated at the beginning of the introductions, we became foster parents because we had a child that was born with a disability. He was born deaf, and going through the early steps process through him with our local Children's Home Society, we learned about the need for foster parents. So we signed up, took the classes, and a month after becoming licensed, we received our first placement. When they called us, they told us it was a 2-month-old little boy who had had some substance exposure and was being removed due to that and domestic violence issues. The 2-month-old little boy they showed up at our house with turned out to be 21 days old, weighing 4 pounds 11 ounces. I was terrified because I had never held a baby that small. My smallest biological child was over 8 pounds, and so having a baby that small was frightening. Backing up to his birth, when he was born, he was the 5th child by this mom. He was the 5th child by 5 different men. And he did not test positive for substances at birth, and his mother did not test positive either. The hospital she delivered at knew a lot of her history, had delivered some of her previous children, and so they actually had the umbilical cord blood tested. But in the interim, Mom, Dad, and baby were sent home and discharged from the hospital. Once the results came back from the umbilical cord blood test, it did show that he was positive for 4 different substances. There were 4 or 5, but it was methamphetamines, cocaine, morphine, and hydrocodone. At that point, there was an investigation opened. Mom was given an in-home safety plan. Part of that included staying away from Dad, who there was at the time of conception and delivery, there was a no-contact order between Mom and Dad due to previous domestic violence issues. The parents subsequently violated the in-home safety plan, and the child was sheltered at 21 days old and came to me. He was born almost 6 pounds, and when he came to me, he was 4 pounds 11 ounces. He came to me on a Thursday night around 7:30, and he was our first placement. When the CPI put him in our arms, she asked us if we were interested in adopting him, at which point we didn't know. This was our first placement, and we were, of course, taught in all of our foster parenting classes, you don't talk about adoption until, you support the goal of the case. And it was her belief that the case would be quick because she got pregnant with this child as she was going through a trial for termination of her parental rights on child number 4. Subsequently, her parental rights were terminated on the 4th child. So we were placed with this child, we were told it would be a quick case. They did end up offering Mom a case plan. Initially, they were going to go expedited TPR. They backed off of that because it was a different dad, and they needed to offer him a case plan. So both parents were offered a case plan. Mom was enrolled in various services. She received a substance abuse evaluation. And even knowing that Mom had a 10-year-plus history of drug use, the substance abuse evaluator ultimately recommended that she receive outpatient substance abuse services. I was really frustrated with that. We were taught in class, not only to kind of advocate for the children in our care, but also the parents, and just being new to foster care and having very little life experience when it comes to drug use and, being around people that used or treatment options available, it did not make sense to me that they would offer her outpatient because they had offered her outpatient 4 previous times with her other 4 children, and it had never worked. So why would we offer the same thing that the definition of insanity, right, is doing the same thing and expecting a different outcome? So I was frustrated with that. As it turns out, as previously mentioned by Pam, Mom had gone into the substance abuse evaluation and indicated that if she had to go to in-treatment, she would lose her housing, she would lose her job, she would lose all these other things that she was going to be required to have as a part of her case plan. So the evaluator decided to recommend outpatient. She participated in outpatient services. She had, I think there were over 20 tasks on her case plan. When I tell you these people, they stacked the odds against her very high and through every service at the book you can imagine at her. She had to participate in child parent psychotherapy. She had EMDR. She had trauma counseling, outpatient treatment. She was seen by the FIT team program. So she was doing outpatient classes. She and I had no communication at the beginning of the case. Well, for quite some time we didn't. Even during our QPI training, they were pushing partnership between bio-parents, system partners, foster parents, everybody. And my husband and I initially wanted no part of that. We wanted to love on babies, fill in a gap until their parents could, get the services they needed to be able to get their children back. And that's what we wanted our role to be. We did not really want to really partner with bio-parents to mentor them. We didn't think that was our role, our job, so to speak. Our job was to take care of their babies and keep them safe. So for a very long time, Mom and I had no contact during the case outside of permanency staffings that we would both be present in person for, and, of course, court hearings. Mom did have visits. She had 5-day-a-week visits, so she saw her child every day. At the beginning of the case, she was checking boxes, and a lot of it she was checking boxes just to check boxes. She had been through this before. She knew exactly what to do, exactly what to say. She knew what they were looking for, and she knew how to some degree to play the system, and she did so. About 6 months into the case, she was missing some visits. She started missing some visits pretty sporadically. And Dad, by the way, when a couple months after the baby came into care, Dad was arrested for another domestic violence incident with Mom, and he ultimately spent the entire case incarcerated, and he's still incarcerated. But Mom started missing some visits, and it was always, Mom has a stomach virus, so she's missing a visit. And it started happening 1, sometimes 2 times a week. And I started to get a little worried, but nobody had any reason to believe anything was going on. Mom was passing her random UAs, and she was still, mostly participating in her services. And at the 6-month mark into the case, we had a staffing, and her FIT counselor announced to the team that she'd had a relapse. She was using meth again. But that she was attending Bible classes and doing really well, and they still didn't think she needed inpatient rehab. And by that point, the frustration level, I think, with some of the other service providers had grown to the extent that they really advocated for inpatient rehab for this mom. Mom pushed back. She did not want to go to inpatient. She didn't think she needed it. She was really angry at the people that wanted her to go. And I believe they basically told her, we're 6 months into this case on kid number 5. You can go to inpatient rehab, or we're going to push for a goal change, and, you're going to be looking at potentially another child that you've lost. And the child that I had placed with me was the only boy out of 5 children. The rest were girls. And she had this really weird's not the right word, but she had this connection and bond with him that she didn't seem to necessarily have with her girls. And I don't know if it was because he was a boy or although her and the child's father to this baby had been together on and off for 10 years, it was the only child she had with him. But she ultimately decided to take them up on the offer of inpatient rehab, which she will tell you to this day saved her life. She went inpatient. She was inpatient for almost a year. During that time, while she was inpatient, she only saw her son 3 days a week. That was what the program allowed. And at some point during that time, so we were 16 months into the case, and one night I was feeding her son spaghetti. And, if you're a parent, every parent has that picture of the first time their kid eats spaghetti, and they're covered, from head to toe in spaghetti. And I took this picture, and I just stood in my kitchen crying, and my husband's like, oh, my gosh, what's wrong now? And I said, like, she should be doing this. This is her child. It's the first time her child's eating spaghetti, but I get this, I get this moment. And my husband said, well, if you're that upset about it, send her the picture. And I'm like, I don't even have her number. But I had her mom's number. I had Grandma's number. And so I reached out to Grandma and asked if I could have her number. And she sent it to me, and I texted her a picture of her son and said, this is his first time eating spaghetti. I thought you'd want to, see this. And it was the start. It was a very slow start to the beginning of what has morphed into a pretty close relationship between she and I. We started small. When her child was in my care, he had so many delays, it's hard to even think back on those times of the number of doctor's appointments we had. I think we had over 50 appointments in a 2-year time span. He had physical therapy, occupational therapy, feeding therapy, speech therapy 2 times a week, and early intervention. He had over 25 therapy appointments a month. We couldn't get him to gain weight. He gained weight pretty consistently until he was about 1. After that, we couldn't get him to gain weight. When he started transitioning from baby food to solid foods, he had texture issues, so we couldn't get him to eat normal food because he was gagging on everything. He had sensory issues, huge sensory issues. Meltdowns were normal. This kid did not sleep. He is 3 years old now. And I still don't think he's ever slept through the night with me. He still gets up at night. He still only weighs about 25 pounds at 3 years old. She still has to take him for weight checks once a month because we still can't get him to gain weight. He did not start walking until after he was 2 years old. But Mom did almost a year in rehab, and then she went to a step-down program that offers a little more freedom than inpatient rehab offered. She got a job. She was able to get a job. We started unsupervised visits and overnight visits in the rehab facility with Mom in the step-down program. She continued to take advantages of the services that she was being offered. I would take him to see her for additional visits that were not court-ordered. She finally started attending his medical appointments with me because it was hard for her to attend them at first because she was in denial and had a tremendous amount of guilt because, she was in denial publicly and would tell people that her son was not the way he was because of the decisions she made, but she knew that her son was really the way he was because of the decision she made. And so it was hard for her to go to a medical appointment and attend a medical appointment and hear the struggles and challenges that her child was having because she knew they were a result of her poor decisions. Interestingly enough, the example that you guys used at the beginning of this presentation, this mom was also addicted to painkillers that she received as a result of a car wreck in high school. And she started taking these painkillers, and it progressed from there. And, soon enough, that high wasn't enough, and so she progressed on to other drugs. She indicated to me that while she was pregnant with the child that I had in my care, she did every drug, known to man. She was doing Molly, Flocka, heroin, everything. And her paramour at the time, and this child's father, was also her drug dealer, and they would shoot up and get high together. And as long as they were high, things were great and the world was fine. And as soon as they would start coming down from that high, they would start arguing. And then ultimately they would end up in a domestic violence incident. Police were often called, and it was just this revolving pattern that they could not break. But like I said, Dad ultimately went to jail and is still serving time. Mom continued to make progress in her case plan. We kept drawing the case out, and I have to be honest with you, I was a bit probably neurotic is an appropriate term to use during this case because during foster parent training, they talk a lot about permanency and children getting permanency in a timely manner, particularly young children, because we know that children, the bonds that they develop in their first 3 years are crucial. And we need children to be where they're going to be permanently quickly. And I was really upset that I felt like, because I didn't understand a lot about substance abuse and, what this mom was going through from her perspective. And quite frankly, at the time, I didn't necessarily care. I was very upset that this child was not getting permanency, and I was jumping up and down and yelling at anybody that would even almost listen to me. But Mom kept trotting on. The department kept extending her time. The judicial system kept extending her time. And ultimately, on my birthday, a child that I had raised from 21 days old until he was 2 years old was reunified. The very first night that he was reunified, Mom called me that day and said, "I have to work late. Can you or your husband pick him up tonight for me because I have to work late?" We picked him up, and since that time, over the first year, we basically co-parented this child with her because Mom did not have a support system. Her whole support system were the people that she had used with, and she knew if she went back to them that she would go back to using again. And even though they teach you in rehab and stuff to build a new support system, that's a difficult thing to do when you don't know how to build a healthy support system necessarily because you've never, and they teach you how to build one, but when you're not used to surrounding yourself with healthy people, it's hard to just go out and, "Hi, I'm a recovering drug addict, but I need some healthy people to be around. Will you be my friend?" kind of thing. And so my husband and I and our whole entire family actually became her support system. And she had a job where she worked a lot of evenings, and when she worked evenings, she didn't have anybody to keep her son. And so on those nights after he was reunified, he would stay with us. And it started out that he was with us about 4 nights a week. And ultimately, the number of evenings she had to work became fewer and fewer. And eventually, the position opened up at our local CBC, who has contracts for case management, and actually advocated for Mom to apply for that position, gave her a reference, and she now works for the agency that was responsible for removing her children. But it provided stability for her and this child, and she no longer needs him to stay with us multiple nights a week and every weekend because she does not have a job in the food service industry where she has these unpredictable hours. They're doing very well. He still struggles. He is still behind in every milestone. He's 3 years old. He can't say his ABCs. He can't count to 3. He did not start walking until after he was 2 years old. He still has major sensory issues. He still has a lot of processing issues. He still has eating issues. He still struggles, and Mom will now tell you this child struggles with the things he struggled with as a result of the poor decisions, that I've made in his life. But through support and building a healthy system and working where she's working, she's learned how to advocate on his behalf. She makes all his medical appointments. She's not used. While Pam was talking earlier, I actually texted her because I wanted to find out if she participated in a medical assistance program, and she had indicated when she went into rehab that she did not have a medical assisted program, treatment program. She did not even take medicine during the withdrawal phase, and she said it was the worst, week of her life. She wanted to die. But here she is today. She's doing very well. I still worry. I would be lying if I didn't. Dad is scheduled to get out of jail in September of this year, and he's a huge trigger for her. And they have such a history that I worry, what will happen when he gets out of jail. And I have to, have faith and tell myself that she's doing very well. She has been doing very well for a while, and hopefully the support system that we surround her with, will be enough to hopefully fend off any temptation that she may have when Dad gets out of jail. But that's her story. I think sometimes the dependency system, I wonder sometimes if it didn't do more harm than good. You can throw all the services at a parent in the book you want, but if they're not quality services, we're all just spinning our wheels. And at the beginning of the case, I did not feel like Mom had a lot of quality services. She had a lot of services, but they weren't necessarily quality, and they weren't necessarily anything that I felt like was really designed to help her overcome this, once and for all. We finally, the inpatient services is what she needed, and I truly feel like had she not gone inpatient, that she likely would not have gotten her fifth child back and probably would have another one on the way, if not already here. But that's our story with raising a child with these challenges, and I'll be happy to answer any questions. I can share my email address, my contact information from you guys. If anybody has a question after this WebEx ends, you're more than welcome to contact me. We will take questions at the end, but for now, I will turn it over to Sherri Dirmann, who is a local former foster and adoptive parent and a personal friend of mine.
Thank you, Danielle. Hey, my name is Sherri. I chose to write some of my story because it's kind of long and a little bit emotional. Pam covered a lot of the issues that we have experienced, like Danielle's story. She kept referring to things that Pam said. So listening to Pam was very interesting because I saw so many connections. My husband and I became foster parents in 2009. In the 7 years that we were licensed, we fostered 11 children. The children were in our home from 12 hours to 15 months, except for the 2 that we adopted, who are now 5 and 8. Our 8-year-old son came to us at 4 months old. His biological mother had already had 3 children removed. All of them had different biological fathers. And my son's father was not involved at all shortly after conception. She had an open case plan for her 3rd child while she was pregnant with our son, and continued testing positive for prescription pain pills. She had a prescription from her doctor for pain pills, but would test positive for several other pills, including her mother's, that she didn't have a prescription for, and always ran out of her pills early. When she was a teenager, her mother gave her pain pills that were not prescribed to her. Her mother and her sister also had addictions to prescription pain pills, and her sister lost her life to an overdose during the case. Our son was born 4 weeks early but healthy. At 4 months old, his mother took him to the doctor's office for a checkup and was unable to care for him or herself due to abuse of prescription pain pills. She couldn't stand up or hold him. Her clothes were on backwards. He was removed at that time. Immediately after removal, his goal was expedited TPR. They had years of cases where mom did not work her plan, tested positive for those 3 previous children, and never even checked the boxes. So their goal was TPR for him. Shortly after that, they changed their mind and decided to give her a case plan and let her try to work a case plan for this 4th child. She worked some of her case plan, but was unable to stay drug-free and didn't enter rehab as required. She attended most of her visits, and even on the visits that she tested positive, she was able to care for him during that time. I had a good relationship with his mom through most of the case. I wrote notes every week updating her on his progress and even asking questions that would help us better care for him. She was open, honest, and helpful. I sent pictures of him every week. She lived about 2 hours away, so when we traveled to attend court or transport for visits, I took pictures of him with his mom so he could have those memories no matter how the case ended. I provided mom with a phone number to call me if she wanted to call and check on him. She chose not to use that. There was a short time during the case that she seemed to be doing well. Her oldest 2 daughters were in the care of a paternal grandmother who passed away. The department attempted to reunify the 2 girls, and we're working on a transition plan to reunify our son. I think she had 2 unsupervised visits and started testing positive again. Her caseworker said that relapse is part of the process, but the plan to reunify was put on hold. After about 2 years in care, the guardian ad litem finally filed TPR. Mom was still testing positive and had not signed up for rehab. Right before trial, she surrendered her rights. Several months earlier, she had surrendered the rights to her 3rd daughter and allowed her foster parents to adopt her. During most of that case, their mother didn't work their case plan and tested positive regularly. An error on the part of the department delayed TPR and adoption in that case. We have a relationship with his biological sister's family and see them about once a year. We try to keep each other updated if we learn anything about their mother that might be important for the children. About a year ago, his biological sister wanted contact with their mother, and we worked to set that up. Their mother was provided with contact information and never followed through. At the time, his mother surrendered her rights. She entered rehab. I know that she's been in and out of jail since that time, but do not know the results of rehab or if she is currently still using drugs. I do know that she went to inpatient rehab. I don't know what she was offered throughout the case plan, but that's what she did, and she successfully completed it. Our son has struggled with behavior concerns since he was 2 years old and was slightly delayed developmentally. He has been in speech therapy, occupational therapy, and physical therapy, but is currently doing well developmentally and not currently receiving therapy. He is on the waiting list for ABA therapy and some other therapies such as art therapy, music therapy, and equine assisted therapy. He is starting grief counseling for the loss of his brother and expressed interest in talking about losing his biological mother through adoption. Like I said, my son came to us at 4 months old and was adopted at almost 3 years old. It has taken almost 8 years to get to the point of getting accurate diagnoses, proper medication, and the correct supports. And I still think it's going to be an ongoing long-term process to make sure he has the help he needs and to be as successful as he can be. He is currently diagnosed with ADHD, ODD, anxiety disorder, disruptive behavior disorder, and learning delay. His behaviors have progressed throughout the years. When he was 2, we assumed it was typical terrible twos mixed with a confused 2-year-old who was being transported 2 hours away every week for 4-hour visits. He was evaluated and red flagged for being on the autism spectrum when he was 2 years old. He would have very long, angry tantrums and had a lot of sensory issues, but was never diagnosed with autism. He was always a very active and busy baby. He was easily distracted and couldn't stay still or focused. He was eventually diagnosed with ADHD. He had fears that we thought were age appropriate, like fears of darkness and loud noises, but never outgrew them. He needed to know what to expect at all times and questioned us for details. He was finally able to verbalize some other fears and concerns. Anxiety disorder was added. His reading delay added a learning delay diagnosis. His behaviors and rages escalated, and ODD and disruptive behavior disorder diagnoses were added. Before he was properly medicated, he would rage for up to 7 hours at a time. He would hit and kick and throw things. He would say the most hurtful and hateful things. Nothing we tried to do would help him. When we would try to reach him, it was like he wasn't even able to hear or process what we were saying. The most success we had to help him through his rages was to find a moment that he would allow it and just hold him and hug him tight. I would rock him and reassure him that he was safe, and we would work through this together. We would cry together until he melted in my arms. His doctor described his ODD behaviors as I don't want to, and there's nothing you can do to make me, and that is exactly how it was. He was in control of everything and everyone except himself. He reserved those behaviors for us. His anxiety controlled his behaviors at school and around other people sometimes. He doesn't like other people to see him crying or raging. He doesn't want to get in trouble or be embarrassed at school. He would let it all build up until I picked him up, and then he was like a different child. I'm very thankful that he had the control to not have these behaviors at school. He is doing well at school. He had a significant reading delay and is almost caught up to grade level, and he excels in math. He is testing a grade level ahead in math. He has a 504, and the supports he receives have really helped him succeed. He loves school and gets along well with his friends. His favorite special area classes are art, gardening, and PE. He really enjoys playing basketball right now and wants to join a team. We love Disney, and he is proud of himself for riding all of the roller coasters except Space Mountain and loves them. He is a sweetheart, is caring, and loves nature. I don't think there's anything I wish I knew about opioid use before parenting our son that I didn't already know. I read a lot and knew the chances of him struggling were possible. I don't think there's anything you can do to prepare for it since every child is unique and there's no way to predict their future. I recommend staying educated on the risks, and taking any concern you have about your child seriously, and then being prepared to fight for what you feel your child needs. I suggest that you have a strong support system. Our son's behaviors have nearly torn our family apart. We had concerns about our daughter being exposed to his behaviors because she was so scared during his rages. It is a commitment and a lot of work to get the help and keep him stable. Even now that he is doing well, it can be a challenge. Our son's doctors remind us regularly that his chance of having drug addictions is increased just due to his history, even if he's never around drug use. This has required us to have these discussions with him at a young age and know that it's something we will have to continue to educate him about. I think a lot of people get into foster care and prefer to foster healthy babies because of their fear of what the older children have experienced or behaviors they may have. Both of my children came to us as healthy infants. There's no guarantee you will avoid those issues. Our daughter came to us right from the hospital at almost 2 days old and had been exposed to meth during the first half of pregnancy before mom was arrested. She didn't have contact with her biological parents except for a few quick visits at court. She wasn't physically abused or neglected, but she does have challenges. Exposure to drugs in utero, a history of mental health issues, and just the trauma of losing their biological families may play a huge role in their future. They need love and a safe place to help them through whatever needs they have to help them heal and be as successful as possible. I'm committed to continuing this journey or adventure with my children and helping them over all of the hurdles and enjoying all of the high points with them. Even through all of the yucky stuff, there's plenty of great moments. Thank you for your time. I'm going to turn this back to Pam for a few minutes.
Hi, thank you very much for that. So what we'd like to do now is open the lines for question and answer, and we can look in the chat, and Diane, I know you're managing that. If you can let us know the questions that come in, and if you have a question directed at a particular parent or to me, if you just, let us know who the question is directed to, or if it can go to anyone, you can say that. So, Diane?
Thank you. We do not have anyone. I'll give you a couple minutes or seconds to type in your questions that you may have for any of the foster parents or for Ms. Petersen-Baston.
And, while you're doing that, I would like to respond to a couple of things that came up with Sherri and Danielle. And so one was I think it was Danielle who spoke, no, it was Sherri who said she had reached out to the mom or one of them. No, I guess it was, reached out to say, did the mom go to medication-assisted treatment? And I guess that was Danielle. And the mom said no, she didn't go. But what she did do was go to a long-term inpatient program. And so that is an instance where, probably the next best thing to having a medication-assisted treatment program would be being in a safe place. The residential programs do have a medical component. So my guess is that while she may not have gotten medication-assisted treatment, in other words, she might not have been on, placed on either methadone or buprenorphine or naltrexone, that she probably got some kind of medication from the nurse, or physician on staff at the residential program to ease her withdrawal in some way or some of the other effects. And of course, it sounds like she was using lots of other substances, so maybe she didn't even have a huge opioid withdrawal at that time. I think meth was one of the other substances she was using. But the residential program provides lots of structure and support, where if she was feeling bad, somebody could have grabbed a hold of her and kind of talked her through it or sat there with her or helped, in other ways so that she didn't, head back out there and start using again, which is very typical. And then the other thing I wanted to mention was if a parent goes to residential, as was the case we just discussed, and she happened to have been pregnant and delivered a baby that has neonatal abstinence syndrome and might still be in the hospital because, often the mom can be discharged and the baby might have to stay for a few days or weeks depending on how severe their expression of neonatal abstinence syndrome. She would ideally be invited to room in with the baby because we know that rooming in and breastfeeding are two things that increase the connection between mom and baby, build a bond that helps the mom's motivation to be able to stay in a recovery program and stick with it, and also it helps the baby. Well, when we heard when we were on the road doing training of instances where if mom is in a residential program, that often the residential program would not let her room in, and she would be staying at the residential program, and they would take her to pump her breast milk so that at least the baby could, have the benefit of the breast milk, and that some of the nurses would pour it out. And so, and we heard story after story while we were on the road. We started in Key West and ended up in Tallahassee and hit every, major area all the way through the state. And it was not uncommon to hear these kinds of things happening. And so, and the clients would talk about how they felt so stigmatized that they just felt like not only pouring out the breast milk was an example that they didn't want anything to do with the mom, and that they felt like she was harming the baby by trying to do the right thing, but also that just the way they looked at her, when she would go into the hospital. So, anything that foster parents can do if you have that, any kind of relationship with the bio parent, and I realize that's not always the case, anything you can do to help address this stigma, because that alone is a major, situation that can, cause that or contribute to that parent going back out and using, is if they feel as if, that they're no good and that everybody thinks that they're not going to be able to do anything positive with their child.
Thank you, Pam. The first question that has come up is, with Matt, would someone stay on methadone permanently?
So that's a great question. So basically, like any medication, it's highly individualized to the person. So, and I used to work in a methadone program back in the 80s, and, times have not changed that dramatically back then, and still now. We recognize that, some people might be on for a year or two, some might be on multiple years. We had, individuals who had, for the very first time in their lives, solid recovery. They were able to work, hold down jobs, buy a house, pay their mortgage, raise their kids, and then they would come off of the methadone and things would go back downhill again. And then we'd have other folks who could, get on it, stay on for a year or so, and then they were tired of having to come in all the time, even when they were getting more take-homes, because you get more take-homes the longer you're there. And so, some were able to get off right away. Generally, the kind of things that we saw were that the individuals, these were all adults, who had long-term drug histories with heavy opioid use generally needed to stay on methadone longer than folks that might have, even if they had long-term drug histories, but more recent opioid experiences where they might have been, dabbling in it and maybe they got carried away and developed a dependency and had to get some help. But a lot of it also had to do with the amount of support that they had and other things that they had going on in their life. People who are involved in domestic violence relationships tend to need to be on these medications for longer periods of time. But we think of it no different than we would, an anti-anxiety medication or an antidepressant, that every individual their biology is different, their genetics are different, their environment is different, the amounts of support that they have or don't have is different, and it's a choice that is made between the individual who knows their risks better than anyone and the medical team. These are not, we don't create arbitrary policies that say you can only be on it for 6 months. We would never do that for antidepressants. We would never do it for anti-anxiety. We would never tell a patient, boy, we're so thrilled you got your life together and you're finally now, not anxious and you're not depressed and you're functioning, so we're just going to take those medications away from you. And we would never do that with any other medical condition. But this is such a highly stigmatized disorder, and for all the reasons that Danielle and Sherri indicated, anytime you have something that has these kinds of detrimental effects on children, it's totally understandable why people feel so anxious about it or so angry and, want to try to, puts these constraints on. Either, you're going to do it abstinent, you're not, some people will say, well, I got my recovery, without having to use the medication, and by God, you should be able to do it too. Well, their recovery might very well have been prior to fentanyl, could have been a completely different mix of chemicals out there. And I make that comparison to, if two people had breast cancer, let's say I had breast cancer and my friend had breast cancer, I would never go up to my friend and say, don't do chemo, just do radiation, because it worked for me to just do radiation. You have no business getting on chemo. We don't make medical decisions for other people. We leave that to the professionals, and that's a choice between the individual and their medical team. Otherwise, again, then we have, put that individual at risk of relapsing. And remember that if you do go through detox, withdrawal management, and which is what you will do at least partially or fully before you get then put on a medication for opioid use disorder. You either have to be partially in withdrawal in the case of methadone or buprenorphine, or in complete withdrawal several days before in the case of naltrexone. That even though you go through this and then you're put on the treatment medications, if you were to go back out and use after these substances are, let's say somebody tells you have to go to a abstinence-only program, and you have gone through detox and you have nothing left in your system, and a few days in you start craving because you don't have the medication to help stop the craving, so naturally you're going to start obsessing on this. You might feel sick, and so if you go out and use then, you could end up, if you use the same amount of opioids that you used to use, that could become very lethal because your tolerance has changed once all those opioids are removed from your system. And that's why we have so many fatalities that happen after someone's either incarcerated and they go through a forced withdrawal and then they get back out on the street and they use at the same level they used to and overdose, or where somebody goes into a program, an abstinence-only program, and they have nothing left, they've been withdrawn, and then they go back out. They decide, or they, for whatever reason, they get back out there, then they can overdose. And that's why the medications are so important, because that keeps the person very level, stops their craving, stops their withdrawal, and makes it easier for them to function.
Thank you. This is for Sherri. Sherri, how would you find the schools helpful and supportive in with your children?
And they've been very supportive. I know that there's a lot of negative views on charter schools. They sometimes don't have the resources that our children need with special needs, but in our case, my son has been provided with a 504, and his teachers have followed it and have been very understanding. The communication has been wonderful, walking through any issues that he may have. We communicate with them with things that we see at home, and they make sure they look for it at school. So our experience with the school has been wonderful.
Thank you.
You're welcome.
Pam, what do you see as some of the biggest barriers to treatment and access for child welfare involved parents with OUD, with opioid use disorder?
The biggest barrier I see is that the helping professionals do not always align the treatment and recovery support and other responses to the severity of the situation. So a typical, if there is such a thing, a typical scenario would be you're dealing with a single mother with multiple children, with multiple fathers. Of course, that played out in both of our examples today that Danielle and Sherri shared. And so that's very complicated, just stopping right there and thinking about multiple children, multiple fathers, you know, and all of the chaos that would go with that. They usually do not have a good education behind them, dropping out of school or just not a good educational history. Few have had any good experience with sustainable wages. They may have had a bunch of odd jobs here and there, a lot of sex work, you know, working in bars, all kinds of things. And they've burned all their family bridges from the different, you know, from lying or from stealing or other things that are not atypical from long-term drug histories. They've had, you know, tons of trauma growing up as a child all the way through to then ending up in a domestic violence relationship with the multiple fathers or other men in their lives. No good role modeling experiences in their own life to even know how to appropriately parent. And we take someone like that, and that's a typical scenario. There's some that are much more, you know, challenging than that. And then we give them, you know, here, you know, just go pop in this outpatient program for a couple hours a week and, you know, get your life together. And often without the benefit of medication-assisted treatment, which, you know, in an outpatient setting is really hard because you might only have a few hours of contact with the program a week, and yet, you know, 24 hours a day, every other day in the environment that you probably are still living in with all your, you know, influences and all that are not healthy. And then we scratch our heads when someone doesn't just emerge in recovery, you know. So we have to do a better job aligning the response with the true scenario that presents with each of these families.
Okay, if you could implement one program or strategy for these opioid-affected families, what would it be?
Oh, wow. I wouldn't even have to think twice about that. The program I used to run, it's not there anymore, it's called SafePort. We treated the entire family. We recognized that you don't just pluck mom out or mom and dad out and throw them in a program or on a bunk bed and shuttle the kids off some other location and then, again, expect everything to just, you know, magically go back to a healthy situation or start in a healthy situation. So in a program like that, I mean, we are spending resources now, you know, sending people back and forth to court, revolving doors, you know, detox, back to treatment, detox, back, you know, in and out of the criminal justice system. And really to be able to implement some of the programs, and they have them all over the country now, where they use either apartment complexes where they, you know, turn them into like campus-style programs where entire families can live and all the needs of the whole family get you know, addressed, and particularly you have on-site supervision. You move the staff right there on site 24/7, so it doesn't require as many out-of-home placements because you have eyes and ears and professionals there at all times. So, you know, to me, unless we get, you know, I'm not saying we shouldn't do what we're already doing, but I think this is a type of model that we clearly need and we know has tremendous success where these kinds of programs are being implemented around the country.
Pam, do you have any thoughts on the resources for this webinar?
Yeah, so at the end of this webinar, we have a number of resource guides that you can use that will help give you some material that you can read and learn about. And if you advance the slides, Diane, to those, we can just point them out real quick. And the other thing I want to mention while that's happening is that the same locations that you will go to hear this webinar back, if you would ever like to do that, the www.fada.training.org is where you will find an incredible amount of training modules that you can listen to. That they're either, I think there's maybe 15 or 20 narrated PowerPoints that you can go to, and also all kinds of other materials and resources and case studies and practice guides. So there's a wealth of resources at the FADA, Child Welfare Family Court Opioid Use Disorder Training website. The first resource, I'm just going to point out 4 real quickly. The first one, called Tip 63, that tells you everything you'd want to know about medication-assisted treatment for opioid use disorder. Now, obviously, it was created in 2018, and we have a couple of new medications on the horizon now, but it will get you fairly current. The next one is Clinical Guidance for Treating Pregnant and Parenting Women with Opioid Use Disorders, and that one will give you the way to connect to it. That one has a lot of great information if you're working with pregnant women. And then the next one, called Decisions in Recovery, Treatment for Opioid Use Disorder, that is very in plain language what somebody who might be seeking recovery could think about as they make decisions about do they want to do a medication or not for an opioid use disorder, and the advantages and disadvantages or pros and cons. And the last one, Family-Centered Treatment for Women with Substance Use Disorders, that talks about the need to do whole family treatment, much like what I was suggesting a minute ago, and how to do treatment plans that factor every family member in, even those that mom may not have custody of right at that moment. And that's it.
Thank you so much, Pam, Danielle, and Sherri, for your time today and for your sharing of your experiences and your knowledge with our attendees today. So as we conclude, we have a couple of items of business before we conclude. When I conclude today's webinar, your browser will take you to an evaluation on FADA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you'll be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile in FADA's system. This helps connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email. The sender will be Messenger of WebEx. Evaluation will close at midnight on Thursday, May 2nd. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as the journal entry within your profile. Your statement of credit will not be, you will not see a statement of credit or certificate of completion until the survey is closed and we have verified the attendance and the completion of the survey. Thank you for participating in today's webinar. We also like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education and for JBS International Incorporated. Have a great rest of your day and please hold for the evaluation.